and they're more horizontally oriented in the lumbar spine. So it's still the same spine, the spinal lumbar junction. The lamina transverse process comes off the lamina, so do the superior articular processes and the inferior articular processes, and the pedicle attaches all those elements to the vertebral body, and the pars interarticularis would be here right underneath the pedicle. Now remember that we're going to call it spondylolysis if it's in a part of the lamina, or even the pedicle for that matter, right? It's still spondylolysis. All that means is that there's a cleft, or there's, it doesn't necessarily, lysis doesn't mean fracture. Lysis means dissolution, kind of. So it can be anywhere, you know, in the posterior elements, exception being spinous process. Nothing's going to happen there other than the spinous process. Okay, so very good. So this is what we're looking at, right? Again, just like in the thoracic spine, the roof of your IVF or neural frame is going to be the inferior aspect of the pedicle of the vertebra above, and of course the floor of your IVF will be the pedicle of the vertebral body below. And then the articulations here and here, right? And you can see how, with hypertrophic changes off of articulations, it could run amok with the IVF and all the components that are in there, right? Forcing them to, compress the portable nerve root, all the blood vessels and lymphatics and adipose tissue and whatever else is in there. You can see the concavity a little bit better here, right? We're probably a little more concave in the lumbar spine, and concavity here, and there's concavity on the sides as well. You just can't see it here. And take a look at the spinuses, they're nice and horizontally oriented. A little difference between, the first and the fifth as far as the central canal is concerned. This is the area that we see involved mostly in lower lumbar herniations, and that's the area of the lateral recesses, right? And then you've got nerve roots and it's the claudia equina that are going through that area. And so you could have a dysplasia of the vertebra above, but because of the claudia equina, you could have pressure being put on the nerve that is going to exit from the two vertebrae below, right? Or I'm sorry, that vertebra and the one below. So, that can be an issue too, and especially if a person has a huge extruded disc like the one that we looked at. Thanks for those of you that came, that was great. I didn't realize that there was a group of young students that were coming through, and they were in their upper years, I guess, in high school. So they were in grade 12, and they're looking to, because they're interested in health sciences, all professions, I guess that's their career day, they got in here. It's too bad I didn't know that they were here, because they could have sat down and they could have participated or heard that lecture. I think that would have been really nice for them. So just poor planning on somebody's part, mine I guess too. But I know that they do come through, but so maybe that's something to consider, and I'll talk to admissions. It could help, right? Get our numbers up. Right? So we can afford better toilet paper. I used to bring my own. Okay, enough about that. Okay. May as well have brought a roll of cellophane or wax paper. Anyhow, all about saving money. Even Obama had out visits in the White House.
Yep.
We're cutting down on the quality of our toilet. Okay, so transverse processing. Stick on the furthest head over. All right, so AP and lateral lumbar. So we talked about all these things, the lamina, the pars interarticularis being there. And you'll notice that I'm talking about that on the AP because I don't have any difficulty seeing the pars on the AP. I guess I could, I'd have to agree that you do see it better perhaps on the oblique, but, sometimes it's not even necessary to take obliques, and we'd be smart to take flexion extension studies to determine the stability of that spondylolisthesis, and curating the patient and taking those obliques. So anyhow, This line here has a couple of spina bifidas on it, right? So persistent non-union, and maybe there's one at S1. I think I had this on one of your quizzes. And if you said S1, fine. If you didn't, fine. I mean, it's not readily apparent. And again, if it's S1 or if it's C1, right? Then we're going to say spondylolisthesis, right? You got that turned down. Okay, and the pedicles are like little eyes. Make sure you check those out, that's for sure. And then this is the sacrum. So here's the anterior SI joint. We come off of the ALA and we come down. If you want to find the posterior SI joint, come up from the bottom of the sacrum, or its apex, and it's in here, and it's in here. More horizontally oriented. We know that the upper 1/3 of our anterior SI is primarily ligamentous, right? So that's why with certain arthropathies, you'll see this becoming ankylosed very easily. Dish does that, and then so does ankylosing spondylitis. Don't worry about that. Okay, so what we're trying to identify here, I've already just go over the psoas. All of the stuff we've already talked about. I want you to be maybe a little more specific, and most of you are. You know, I want you to talk about, if I outline, for example, here, the white would have to be the superior articular process of this vertebra, right? Whereas the pink would have to be the inferior articular process of this vertebra. So I would like to say either inferior, you know, articular process, or if you say facet, that'd be fine. I don't know who else use C joints, but I mean, everybody says C joints. That's good. I mean, sigmopoplacele is what the Z is making reference to, but you know, realize that other people may not know what is meant by your C joints. Right? So maybe say sigmopoplacele. Okay, so this is what we're trying to do here. It's not so clear because you can't see it way over here. There's a kidney. There's a kidney there. This is just sigmoid, colon, kind of not so S-shaped, but supposed to be kind of S-shaped. And then the rectum would be more vertically oriented. I don't know if we have, it kind of looks like you might have the tropism here, right? Sagittal and coronal, but I don't know, maybe it's just a little off, and there's a little bit of obliquity to it, because I'm thinking that maybe there's a lucent line there. Okay, let's look that slide. This is straightforward. Intervertebral disc, or disco-vertebral junction. What did I call it? Solid fluid. Just intervertebral disc. I'm trying to think of another word, sometimes you know what now. But discovertebral junction, or intervertebral space, sometimes they have disc in there, they don't. Okay, and then these are the ivy caps. And then this area here has to be the pedicle. Right? And then of course, superior articular process, inferior articular process transverse, and then underneath that would be the bars. This would be the first sacral segment. This is the sacral base. This would be referred to, you can see a little bit better, the anterior sacral promontory, and then a spinous process. Okay, so make sure that your links down. It seems that inevitably there's always a few that don't seem to have that down. Remember, we said that in the cervical spine, when you're looking at your anterior obliques, you're looking at the same IVF as the shoulder that's touching the bone. However, in the lumbar spine, because we're looking at different structures, the bars and vertebrae and the articulations, that if you shoot, for example, posterior oblique, you're looking at the same. So the cervical spine, anterior obliques are the same as the shoulder that was touching, but in the lumbar spine, posterior obliques give you the same dog, Scotty dog, or sigmopoplacele joints apart as the hip that is touching, right? So don't confuse the two. 713, yes, one of our okay, so So if this is a left posterior oblique, the Scotty dog that we're identifying here has to be the right Scotty dog. I'm sorry, left Scotty dog. Left Scotty dog. Okay, so this is the eye of the Scotty dog, which is the medical that was on the quiz. This would represent the neck, right? So this would have to be the left pars, right? This would have to be the articulation, the SI joint. And that would be the left, left one. Yeah. And then this would be the pedicle again, and then the articulation there as well. Oh, this is the opposite. That makes sense. So, the same as this one. Yeah, this would have to be the opposite. Or the opposite. So all of the dog stuff is left stop and this and to the right. Okay, so here we are again. Here's the body of our Scotty dog. That's the lamina. This area here behind the body, which is the spinous and the inferior and superior process, and the tail and the back, you don't worry about because you're going to shoot the other oblique. You always shoot a right, you always shoot a left. And then, of course, the nose of our dog is the transverse process, the ear of our dog, superior tubular process, the foreleg or the front leg is the inferior tubular process, and then if our dog has a collar, we say that they've got spondylolysis. It's like a little. Okay, so this is all now very redundant. High pedicle, transverse process. This is an RPO, so this has to be the right. So, okay, we didn't talk about this much, flexion and extension. There's no justification if you think that, L5 is the only vertebra that is with a pars defect, or if you suspect the possibility of hypermobility, which could result in instability, you might want to just do a lumbosacral spot, right? Make sure though that if it's like L3, that you're including either the 12th thoracic or, the sacrum. So you can have, a reference, make sure that it's L3. Lateral bending we really didn't talk about. Some people can laterally bend more to one side versus the other. You can see that when this person laterally bends, it's the same person based on bra straps. But their curves aren't quite as smooth. I mean, this is probably more what you might expect, I would think, than this. And it's also true that here it looks like the spinous processes, and of course we should be looking at the pedicles, by the way. That's one thing that you need to remember is that when you're looking for rotation of a vertebra, look for the pedicles, not for the spinous process, because they can deviate, and that can just be the norm, right? So it's a structural situation. But anyhow, it kind of looks like maybe we're not rotating these vertebrae here as much as we should, maybe in the lower lumbar spine. And maybe we're rotating them a little more than we should here. So anyhow, you're comparing one lateral bending to the right versus the left, and to see if there is continuity, and there should be. Okay, so now we talk about spline menstruation, lumbar angle of lordosis. So we said that should be somewhere between 35 and 45 degrees. And so any way you look at it, we could be talking about, the set, especially if it's more, because that would be posterior wedging of the disc, right? And if it's less, it could maybe reflect that there could be, this is not very reliable for disc herniation. Anymore, the only reliable choice is MRI. Even if you're looking at plain film, it has to be supposition, right? It's a suggestion, and that's it. Okay, usually, Yeah, usually with, especially thoracic scoliosis, you get a reduction of the lordosis. I'm not 100% sure that I can say that for lumbar spine, but kyphosis, we do see in the thoracic spine. Okay, so here, take L1, you're not gonna have to draw these, so if anything, I would show you this, ask you if it's a normal one or not. We know that we need to evaluate the small angle, not the large one, the small one, and it should be 35 to 45. This is not terribly reliable. Lumbosacral disc angle, the purpose is pretty much the same. We're trying to evaluate for the set implication, and if it's more than 20 and less than 10, you know, it could be disc herniation. So now it's just the relationship of the fifth lumbar to the sacrum. So you just draw a line along the anterior end plate of L5, the sacral base, and this is the angle that you measure. The quick rule of thumb is that if these lines, you can see them intersecting way back here where the spinous is, but if they were to intersect here where the articulation is between L5 and this one, then probably a pretty good punch that you've got for set implication, right? And then that would give you a severely posterior wedge disc, right? And you definitely would be exceeding, 20 degrees. Okay, so that was the lumbosacral disc angle. This one here is the sacral base angle. It's also called Ferguson's sacral base angle, right? So 26 to 57 degrees suggests that an increase, again, has to do with the set imbrication and problems with your articular facets. So you should remember these angles. If you think about it, we don't have a lot of aids to help us determine, what really is happening with the articulations, which is where we probably do our finest work, right? As chiropractors, mobilizing articulations, and of course we do a lot of wonderful muscle work too. But that's what the adjusting is all about. We're adjusting into the articulations any way you look at it, right? So the importance of that, I think, goes without mention, and national boards probably thinks in the same light, or whoever puts the test together. It's administrators as well as educators that put that test together. So they're the ones that are probably saying, oh yeah, these are important numbers, and for the most part are, but not necessarily are they reliable. So we ignore that part. All right, so anyhow, still using that line along the sacral base, and now we've come up with our little wheelie ruler, that I told you about in the Office Depot, and then you draw a line parallel to the bottom of the film, assuming that the patient is standing on a flat surface, right? And then, again, small angulation measurement. All right, so, we could have done it here, we could have done it. This section here is a little more horizontally oriented. Ferguson's gravity line, it's also the same gravity line, basically, but we can call it Ferguson's. In the cervical spine, we didn't seem to care where that line was in the thoracic spine. It's somewhere out in limbo there in front of the spine because of the kyphosis. But we do know that that same line that we drew from the tip of the dens that went through the anterior 1/3 or 1/4 of C7, and now it's traversed the thoracic spine, is going through the middle of L3, and then it's going to go through the anterior sacral promontory. So, and then you talk about anterior if it's in front of the sacral promontory, or you're going to talk about it being posterior if it's like the mid 1/3 or posterior 1/3 of the sacral base. So here we're just picking up the anterior aspect, and we're doing good. So this would be normal, and then here, because they do have a spondylolysis, can't see it very well, but this is anterior. And we talk in terms of mild, moderate, or severe. We don't measure it, right? We just eyeball it. So it's all based on, the data that you've accumulated over time as to whether it's mild, moderate, or severe. And we say that you can say mild to moderate or moderate to severe if you want. Here it's posterior, substantially. This is the one true that I told you, so you should know it. That is Hadley's S-curve true chiropractic line of menstruation. I don't know, I'm assuming Hadley, Dr. Hadley, chiropractor, is going to come up with this. So what we're trying to do is evaluate again, that leading component that we have to diagnose and analyze chiropractically. So it could be imbrication, it could be osteoarthritic changes, it could be anything that afflicts the Z joints. Okay, so it's on the AP and it's on the oblique, not on the lateral, just the AP and the oblique radiograph that we draw our Hadley's S. So we pick up on the AP, the underside of the transverse process, go down the inferior process, pick up the superior process, and then we keep on going like this, and do other segments as well. And then you're looking for discontinuity, right? And have a little bit of that there. With the oblique, you come down the nose of the Scotty dog, and then, the neck of the Scotty dog, and this is the area, this is the hypophyseal joints here, that you're looking for discontinuity. And that discontinuity could also be, it's not just necessarily gapping or space, it could be that there's, say, a decrease in disc, this disc might be compromised, and so the superior articular process could be jabbing into the neck of your Scotty dog or the vertebra above, right? So, and there could be hypertrophic changes coming off of this. So those are the kinds of things. We don't get enough gapping of our articulations in most instances where we get out our rulers and measure, because they're just small measures. In some cases, if you've got something like degenerative anterolisthesis, then you can get what's called the W sign, where the articulations have been eroded, then you can see those substantially. Right? But with a lot of degenerative processes, it's hard to see those articulations because there's sclerose and there are hypertrophic changes above them. So this is kind of the latter situation that I spoke of, where the superior articular process is sinking into the anatomical neck of the Scotty dog. So that would be abnormal. This is more normal. Those of you that went to the discussion, I had 38 slides and I had Dr. Weil was giving me, the look that I only had so much time left, right? I don't know, I just felt like I was rushed through it. Did it come across rushed? No?
Yeah, it was quick.
It had to, I mean, because I was just stumbling and it's like, I'm watching Dr. Wyatt and 1 minute, I thought I was on Top Chef or, who's that English guy, that man? He's Man Ramsey. He's a man. Yeah, he's a man.
It's typical British.
It's very belittling. I don't know why they didn't want to be on the show. But anyhow, I felt like I was on one of those Top Chefs or something, where I only had so much time and I was running out. So, anyhow, fewer slides. I should have actually shown the case first, and then I could have talked about all this stuff later. That would have been smarter. Next time. Okay, so this was the Meriding. We better go back. This was Meriding. We take the. It doesn't have to be just a sacral base. I mean, it could be L4 relative to L5. So you would take, in that case, the superior end plate of the L5 vertebra. But usually it's L5 where we have a problem with pars defects and anterolisthesis. So we would take the sacral base and we break it down into 4 quadrants, right? 25% each. And I think it's better to talk about the percentages rather than, oh, it's a grade 1, it's a grade 2, grade 3. I think we should talk about 20%, 35%, whatever like that. Always something in between. It's not discretely 25, 50, 75, 70. Okay. So that's what we're doing here. And it's the reference of the posterior inferior aspect of the vertebral body relative to those quadrants that you established on the sacral base or the vertebra itself, or that's involved. Okay, so here, grade 1, and your count goes from back to front. 25%, 50%, 75%, etc. Here we've slipped off the spine, so there's conceivably a grade 5. Right? Here you can see when you evaluate the posterior, inferior aspect of the vertebral body relative to your quadrants, that we're kind of somewhere around here. So I don't know, maybe make that 15%. Here, where we've slipped off of, and it doesn't have to be that you slipped off of the sacral base, but remember this is referred to as the what? Bowline of Brailsford, Napoleon hat, or John Donne's cap, inverted Napoleon hat sign, and John Donne's cap. But just know those terms. What you're seeing here, this density, is this vertebral body, as it's overlying the first sacral segment, so that's why it looks so dense. It's like a double density, right? Whereas all these others are just singular densities, right? So that's what's going on there. Okay, Ullman's line we also use to evaluate a patient that has spondylolisthesis. And all we do is draw a line along the sacral base, and then from the sacral promontory, we draw a perpendicular to that line. And now we're making reference to the anterior-inferior aspect of the human body, trying to determine whether or not it's gone beyond that upright. And if it has, then probably you've got, slippage of the vertebra. Now, understand that there doesn't have to be a Carter's defect. You can have slippage, right? You see that at L4 more commonly with degenerative anterolisthesis, right? And we said that the degenerative anterolisthesis, the vertebra only moves about 25% or grade 1 in the lifetime of that individual. The problem with the degenerative is that as much as, for example, spondylolisthesis opens up that central canal, degenerative really does close it down, even though the vertebra is going forward. But what's happening is that you've got all these hypertrophic changes off of the posterior articulations, maybe posterior aspect of the vertebral body. Add to that disc lesion, add to that synovial cyst coming off the Z joints, added to that buckling of the ligamentum flavum. All of that is compromising the central canal. So just because you've got slippage doesn't mean that the central canal is going to be widened. It is with bilateral spondylolisthesis, but not with degenerative. Another thing to consider, though, is that instead of having the neck of a Scottish dog, it's more like I said before, the greyhound. So you can have some structural differences, right? I mean, that's just congenital. So brings up an interesting point. Also, we said that the inferior end plate of, say, L5 in this case, and the sacral base should measure exactly the same. If they don't, then you've got a pseudo either anterolisthesis or retrolisthesis going on. Okay, so here's our Ullman's line. This represents a norm, right? And then this one here, inferior aspect of the vertebral body, has gone beyond the perpendicular line of the upright. Oh, you've got the other class. Sorry. Well, it's a good thing. So in a particular space, we said that, and this is what you really need to know here, is that the distance between one pedicle and the other, if it's increased, it's either a tumor or there's some sort of abnormality. Now, generally, the tumors are probably neurogenic tumors, something like neurofibromatosis, or some space-occupying lesion that's going to erode the pedicle. And another thing that you need to consider, and I don't have it here, I need to add it, is that if there's trauma, especially in the lumbar spine, and that would be specific for Smith fractures and chance fractures that you're going to get taught, Dr. Thompson's going to share with you next trimester. So those are nasty fractures, and that'll cause the increase in the interpedicular distance. When it's decreased, that's usually because of stenosis, whether it be acquired or whether it's dysplastic. So the person, was kind of born with that, and it's congenital. One of the things that we can see is a trifoil configuration to the central canal. And when I say trifoil, it's like a clover leaf. Okay. Actually, let me go back here for a second. It's not too far. it's a distance. The trifoil would be where this area in here is kind of narrow. So you would have like one of the clover leaves there, one of the clover leaves there, one of the clover leaves there. And so this area kind of pinches it off so that you've got your like 3-leaf clover, one here, one here, one here, and these narrow areas here are narrow. Okay, so. Okay, so, very good. All right, sagittal canal, I want you to know that it's also called Eisenstein's method, right? Little Eisenstein. What did we say that it went in the cervical spine? What did we say the measure was? For stenosis? Was it 12? Yeah. Here, because the lumbar spine is a little bit bigger and there are body plan, I don't know, maybe goodness. We're talking 15 minimum, so anything below 15 is probably spinal stenosis. Right? And the best way to evaluate that, it's not doing Eisenstein's method, but rather CT or MRI. So, a line along the posterior aspect of the vertebral body, you would go to the apex of the superior thecal process and inferior thecal process, draw a line, and this is the measure here. So if this were measuring below 15, then you got trouble in River City. So that's the sagittal canal measure, and again, it's for spinal stenosis. Okay, so let's see what we want to do. Oh, it's 10:02. Got a little late started, you know. Well, why don't you take 10 at the most minutes?